Good morning, everyone, and welcome to Lyric. We'll have a proper introduction 9:15 with the scientific director of Lyric, Professor Olivier Bernus. So thanks first of all for waking up so early. Thanks so much, Roman, for coming early this morning to help me set up the stage. We dive directly into science with two great speakers today. So I'm going to call on stage Ruud van Niswijk from CHUV Lausanne. He's going to talk about CMR acquisition and fluorine-19. And then we're going to have Dr. Bruno Caisson, who is leading the imaging team of Lyric for a few words on thermometry. And let me introduce you to our moderator, Dr. Dounia El Amrani. She's a researcher in the imaging team at Lyric, and she's going to moderate this session. Thanks so much, Dounia, and thanks, Ruud. Dounia, do you want to say a few words?
So welcome to the cardiac imaging workshop, and welcome to Bordeaux. The first speaker is Dr. Ruud van Niswijk. He's a senior lecturer at Center for Biomedical Imaging of the University of Lausanne. And at Lausanne University Hospital, his research focuses on cardiovascular tissue characterization with MRI. And he will introduce us today to MESIC CMR and fluorine-19 MRI.
Thank you very much for this kind introduction, and thanks for letting me kick off this no doubtedly great symposium or workshop. So I'm going to talk to you today about the basics of CMR and the basics of fluorine-19 MR. And I have quite a few things to cover. For many of you, this will be very well-known territory, so you can nap a little bit longer if you want for the first bit. But then you really have to wake up for the second part, because that's where things get really interesting. So I'll start with, of course, the most important part of cardiac MR, which is motion correction. And I got most of these slides ages ago from Matthias. I meanwhile modified them heavily and so on. So any mistakes are without a doubt mine. So this image you might have seen also several times before. This is one of the first MR scanners in the world on the left from Aberdeen with Bill Edelstein next to it. And on the right, you don't see a funny tapestry or something like this. This is one of the first cardiac images, or even the first cardiac image that there was. And if you look on the left and the right, you can kind of see the arms, and you can see the chest quite easily. But the heart, of course, is completely blurred. So for imaging the heart, this was not really a big success yet. However, if you would repeat this now in one of these modern, very fancy $1 million MR scanners that the companies build for you these days, and you just acquire an image of the heart, what you get is the image on the left here. So not that much better, to be honest. And where we want to go is something like this here, the image on the right, where you can nicely see the coronary arteries aligned. So we need to correct a lot of motion to get from the left to the right image. And why do we need to do it? Well, there's several types of motion that affect the heart. There's intrinsic cardiac motion, which is caused by the cardiac cycle, of course. It causes a movement of about 2 centimeters. There's extrinsic motion, so the respiratory cycle, so 12 breaths per minute or something like this. Also 2 centimeter motion. And in many applications, unfortunately, the MRI data collection period is quite long compared to this motion. So we need to do something else than just acquire fast. Because if you just acquire fast, like you can see here on the right with an X-ray angiogram, then we don't need to correct for any motion here. The frame rate is sufficiently high, and each frame is completely acquired that during this frame, basically, there is no motion. But that works. But if we do use things like stronger gradients, shorter repetition times, parallel imaging, compressed sensing, etc., then we still are not at this level with MR yet. So we often, especially if you want to do mapping or 3D acquisitions, we have minute-long acquisitions still. And of course, if we do these things above, we run into things like nervous stimulation, RF deposition, and strong acoustic noise as well. So we want different solutions. The most well-known one that, of course, you all know is ECG triggering. And here, essentially, you combine a trigger from part of the ECG waves, or part of the ECG signal, so the R wave, the big peak you see in the middle, together with K-space segmentation, and you collect a small bit of data each heartbeat. And that is, of course, during minimal myocardial motion, either in the endosystole or in the mid-diastole. And after you get the complete K-space, you Fourier transform it, and ta-da, you get your picture out. But this, of course, necessitates reliable ECG signals. Now, if we just use ECG and let the person breathe freely, we already go from this uncorrected image to this. So just case-based segmentation, you still see some artifacts, and the coronaries are not very clear yet, but you get quite a big improvement. So this is really the main, the workhorse of motion correction, essentially in cardiac imaging. It's ECG triggering. Then we also need to get rid of that respiratory motion. And this can be done a whole bunch of ways. You can do averaging, so you just acquire your signal multiple times, and your motion artifacts from respiratory signals will just average out. You can use respiratory bellows, so a belt around you, and then use the signal from this belt to guide your acquisition. You can just hold your breath, and you can use navigators, so you can use some kind of MR data. Breath holding has a lot of advantages. It's easy to implement. It's not vendor specific. It has short scan time, or well, you can use it for short scan times, and it keeps your scan times short. And so it's preferred for fast 2D imaging. So things like function, perfusion, scar, and so on. However, breath holding has some disadvantages as well. You can see the drift here over a single breath hold. It has some repeatability problems. Here you see a scan that consists of multiple breath holds, and these don't really align. So then your images also don't really align. And so it has some disadvantages as well. The single breath hold duration limits the spatial resolution. You get the diaphragmatic drift that I showed before, and this misregistration of multiple breaths. And of course, you have a lot of operator-patient involvement. So you need to really tell your patient, and your patient needs to understand you, needs to speak the same language at least, and needs to want to work along. So the first solution for that was the lung liver navigator. So you track the displacement of the diaphragm. So if you're acquiring the image of the heart over here in this image, then you place, for example, here an extra navigator on the side. This is a 1D acquisition, as you can see on the right here. It goes very fast at the moment. Normally it's not this fast. But as you can see, you have basically an acceptance window in green there. And only the data, or only when the navigator or detection falls within this green window, then you will acquire data. But this is basically the transition from the lung to the liver. So lung is dark, liver is bright signal. This is very simple for any even older computer to detect. And so you can really inform your acquisition based on this. It has several advantages. The breath hold quality doesn't govern the image resolution. You can just keep on going and acquire very long scans. There's no operator or patient involvement, so even that patient that speaks another language is fine. And then it's flexible for high resolution 3D acquisitions, etc. And it has been demonstrated in a multi-center trial by Matthias and friends a long time ago already. So going from this uncorrected to the ECG triggered image was this transition we saw before. And now if we move to navigator gated, now all of a sudden the coronaries are very bright and sharp. So yeah, we're good basically. We've corrected for most motion. There are some drawbacks though. We really need that lung-liver interface to be exactly within the acceptance window, so you have a very limited and unpredictable scan efficiency. The patient can change the breathing pattern, can fall asleep, for example, and all of a sudden he doesn't go into that acceptance window anymore. You have an infinite scan, for example. There are some temporal delays and hysteretic effects. So as you can see in the diagram on the bottom, not all people breathe in and breathe out the same way. And that changes the relation, of course, between the diaphragm position and the position of the heart. Placing this navigator, which is sometimes a crosshair or sometimes a dot and so on, that needs to be in a very exact position, is a relatively complicated planning for the technicians, so they don't like it either. And it's of course a point that goes wrong. Each vendor has their own solution for this as well. And most famously, there is an empirical factor of motion between the diaphragm and the heart. So basically, there was a paper a while ago that over a large group said the relationship between the diaphragm and the heart movement is 60%. If the diaphragm moves, then the heart moves by 60% of this. And everybody took this value for granted, basically, and has been used ever since. And of course, patient bulk motion is still not accounted for. So one next step was the respiratory self-navigation. David will probably tell more about this tomorrow as well, where you can use, for example, there are many types of self-navigation, but what you can do, and what is done in Lausanne a lot, we can use a superior-inferior readout, so a single readout, and track this signal basically and correct your data through cross-correlation with this. So for this, you need to do a few manipulations as well of the data. So you need to make the heart stand out quite well. So you select, do some coil selection, as you can see over here. And then essentially you can follow the blood pool over time. And now you can just align basically all these little segments with the signal that you get here. And the nice thing is here you have, that you have really 100% efficiency in your acquisition, because you don't need to wait for things to be accepted anymore. All data sets, all bits can be used. And of course, there are many different techniques that did similar things to self-navigated data. Finally, there's also bulk motion. So when the patient really shifts and so on. So non-cyclic motion, what people that study the brain often look at, right? When they just turn the brain once and so on. And this is very hard to separate from cardiac and respiratory motion. But it's good to remember that it exists also for our more cyclic motion-oriented motion correction. So basically, what we do in cardiac MR is to inform the patient, just don't move. And indeed, we limit the mobility, so we strap them in quite tightly and so on. And of course, we just limit the scan duration, so there's less time to move, and we maximize the patient comfort. So that's it about what I wanted to tell about the basics of motion correction. So that's, now that we know this, and that this is the most important thing, the motion correction, we can look at changing contrast. And that really goes as a function of the motion correction. So if we need to acquire as fast and robust as possible, and we can only change the contrast as a function of this, at least in most cases, everything becomes kind of building blocks. So what we do is we have this fast, robust acquisition we see on the right. We have a navigator perhaps in front, and then we add some Lego blocks basically to generate contrast. So here we have the timing of the ECG. So the red arrow is on top. So this stays fixed, and then we adapt our contrast generation next to this. So this can be many things. As you can see here, the contrast can be generated with inversion recovery, saturation recovery, T2 preparation, fat saturation, etc., etc. But you all do kind of the same thing. They take the timing of the motion correction and so on into account, and then add on this contrast generation. And of course, this can be done with or without a contrast agent. Now, just to highlight one or two of them, inversion recovery, you probably all know, is the equation you see there in the bottom. You invert the magnetization, you wait for the recovery of the signal, in this specific case, that's used a lot in cardiac MR, we inject a contrast agent and then exactly wait for the signal of the myocardium to go through zero, and then image the blood pool. So what you then get is going from images like on the left, you go to something on the right here, which is an inversion recovery image post-gadolinium. And the other thing that is used a lot in cardiac MR is functional imaging. Don't let the brain people hear that though, but yeah, it's still a measuring function, so it can be called fMRI if you want. But this is indeed used to establish ventricle and muscle volume, inspecting contractility, etc., etc., and results in the images that you probably know well to see in the bottom. So this is, again, a segmented acquisition, but instead of acquiring one little segment per heartbeat, you basically acquire them continuously. So in your first heartbeat, you will acquire the first two lines of the first frame, then the first few lines of the second frame, then the first few lines of the third frame, etc., until you've got a bit of all your movie frames, all your scene frames. And then in the second heartbeat, you collect the next few lines and so on, say, indeed, as is shown here, line 5 to 8 or so, and etc., until your entire case space is filled up. So even though it looks like a real-time movie, it is not. And when you look for artifacts in this kind of image, you need to keep in mind that it's acquired in this segmented fashion. There are two main ways to do scene imaging: prospective, so you wait for an ECG for a fixed number of phases, and this way you will probably miss the end of the heartbeat, or you might skip a heartbeat because you fixed your basically length of the acquisition, and a patient's length of heartbeat always varies. Or you can do it retrospectively, so you just use whenever a new ECG trigger comes in to switch to the next heartbeat. However, this needs quite robust ECG triggering, essentially. Then finally, the technique that I want to discuss is tissue quantification with cardiac MR, which I do myself quite a bit. There are many flavors of this again. So you can do spectroscopy, which characterizes something in the tissue. T1, T2 mapping, T2 star mapping, etc., etc. You can quantify diffusion, chemical exchange, and so on and so on. I'll illustrate things a bit with T2 mapping, which I'm most familiar with, but all the other ones are indeed, they work along similar mechanisms, except perhaps spectro. So if you normally have weighted imaging, what I showed before, essentially, so right, black and white grayscale images, they have some disadvantages. They're qualitative. The signal varies a lot. They can be misinterpreted easily due to artifacts. And so there's really a need for mapping. Even if you're not that interested in the quantitative values, you remove a lot of these variabilities that you get from weighted imaging. So the relaxation times only depend on field strength and physiology. And it can be compared between patients and sessions because you get numbers. So how does it work? You essentially increase the time when the magnetization is transverse several times, and then you fit the signal loss in each pixel. This is classical mapping, essentially. So you do, for each pixel, you map, for example, with T2 mapping, the signal against your echo time, and you get an exponential decay. And in each pixel, and now you take this value out to T2 here. These days, of course, there are many variations and advancements on this, but this is how it tends to work. Here's what I used to do, or still do actually in the heart. You do some kind of robust imaging, so spiral imaging, BSFP or GRE, and combine this with a variable T2 prep. So we have a very robust. We get just 3 images, we fit these 3 points, and we get a nice colored map out like this. So the take-home messages from this intro to basic CMR are indeed that you always need robust motion correction for cardiac MR or cardiovascular MR, and that's really the basis of most imaging sequence, the first thing you need to think about. Then you can start thinking about generating contrast, but only then. The scene imaging that I showed is the most widespread cardiac MR technique, and many tissue parameters can be quantified at the cost of time. So now I want to switch gears and talk us briefly about fluorine MRI. So far we've been talking about anatomical imaging, so that's non-invasive, images abundant water. You have a very high MRI sensitivity, the highest gyromagnetic ratio of all nuclei, and you get contrast to chemical and magnetic tissue differences. But you can also look at other nuclei, carbon, nitrogen, oxygen, etc., and among them fluorine. So fluorine 19 is not fluorine 18, that's used for PET, right? That's radioactive, etc. Fluorine 19 is completely stable nucleus, and there is no natural fluorine 19 in the body that you can detect with MR. There's some in the teeth, but that's fixed and bound, so you can't detect it. And it has 85% of the sensitivity of proton, so which is the second highest, basically after proton. But so since you don't have natural stuff in the body, anything that you do inject basically is your contrast, essentially. So anything that you see here. So Matthias gave me this image ages ago from some guy that did something in Italy a while ago. If you add fluorine MRI, if you would inject fluorine, you would get a signal like this. So much easier. What I do, very simple images. And then, of course, you would overlay the two of them, and then you would have your localized signal. Now, why do we want this? Why do we want to inject anyway fluorine? So this brings us back to James Cameron in the 1980s. I don't know if you ever saw this movie, The Abyss. They go deep sea diving, and then they say the pressure is so high that you can't breathe air anymore. You need to breathe liquids, and these liquids are basically perfluorocarbons. And that's actually real. Here you see a mouse basically breathing in perfluorocarbon because perfluorocarbon has a higher concentration of oxygen per volume than even air does. So this overcomes the partition coefficient for the lungs and so on. It's also, of course, then been picked up by cyclists because, of course, why not? Cyclists use this as blood doping. And the molecules look like the one you see there in the middle, so highly fluorinated. So all the hydrogen's been replaced with fluorine. People have also played this as a blood volume expander, so they've injected up to 0.5 liter in people already as a blood volume replacement after traumatic blood loss. Here you see more of these molecules, what they can look like. You can also do very targeted imaging with it, so you can attach some targeting ligands. You can add fluorescent probes as well to the histology afterwards and so on. And what I'm always interested in is this injecting the perfluorocarbon emulsion, seeing that it's taken up by immune cells, then having these immune cells travel to some site of inflammation, and then waiting for it to be cleared from the blood, which happens in a day or so. So you inject it one day, you image the next day, and then you image inflammation. Then the really cool and unique thing of perfluorocarbon is that it reflects the immune cell presence over time. So if you see the image on the left here, they injected some perfluorocarbon and an irritant that causes inflammation in the fat pad of a mouse. And then over time, this inflammation went away, the perfluorocarbon went away, and the irritant went away. And as you can see in these curves on the right, they really nicely show that you can use fluorine MRI to track inflammation over time. So the advantages are that you have no background signal, that the signal is kind of the present perfluorocarbon quantity, so it can be used for quantification. It's inert, so it allows for easy translation. It clears from the tissue over time, so it can be used for monitoring over time. And its main disadvantage is that it really requires special hardware, so you need a fluorine coil, etc. And it has relatively low SNR, so nowhere near as sensitive as PET imaging. Then I want to show quickly a few studies that we did ourselves. Quick look at the time, so I'll hurry up over there. One of the studies that we did is we imaged myocarditis in a mouse model. So this is inflammation of the heart tissue. And as you see here on the image on the top left, is that even the right ventricle wall, which is very, very thin in mice, gives a very clear fluorine signal when it's inflamed. We also confirmed this ex vivo. Then the histology, as you can see here, you have infiltration in only a small part of the right ventricular wall, but that's still nicely showed up in the images. Then the other thing that's very interesting is even with this disease model, which is a very light myocarditis disease model, you don't get changes in the injection fraction yet, so no visible disease yet, as you see in the bottom right, but already the disease degree nicely correlated with the amount of perfluorocarbon that we had present. We did something similar in atherosclerosis, so looking at the inflammation in the plaques in mice. There we could also nicely detect the inflammation in atherosclerotic plaques, both in vivo and ex vivo, and then scan the aorta overnight. Right, the mouse aorta is like this thick or so, 1 or 2 millimeters thick, and then even in the branches we could nicely detect the inflammation. And histology nicely confirmed the presence of these on the co-localization of the perfluorocarbons, which are here in green, together with the macrophages in red, so that the signals become yellow in the bottom right. Now, of course, these are all mouse and animal studies and so on, very interesting, but now we want to translate this to the clinic. So we want something that gives a unique application, that is highly specific and sensitive, needs to be regulatory improved, right? We're going to inject all these perfluorocarbons. So we need a lot of improvements. So first thing we did with imidazole was to increase the sensitivity. So if you have a standard image here in the middle, we worked together with Jerome and some people from Siemens, applied some funny combination of averaging and compressed sensing, so undersampling one bit and then using that time to average another bit, and this really improved our sensitivity. We did some optimization of acquisition protocols, etc. So getting the best simple echo times, pulse sequences, repetition times, and so on out. And some other people, they did a confirmation in large animal models. So here you have a pig model of an infarction, as you can see with the balloon in the graph on the bottom left. And the perfluorocarbon very nicely lights up the infarcted area. But then if you combine it with LGE, so late gadolinium enhancement imaging, that images the scar, you can very nicely see that the perfluorocarbon signal, as you can see in the bottom graph, very nicely localizes with the inflammation histology and not with the scar histology. So it really gives a separate biomarker. Then we did some characterization together with the startup company in Scotland of a new perfluorocarbon that's already approved. So this can be used in clinics in humans basically the moment we get the documents. And this in turn led to a clinical trial that we've now just we're setting up at the moment. So we're waiting for the last OKs from this perfluorocarbon, and then we're going to study acute inflammation in carotid artery plaque. So we will recruit patients that have had TIAs or strokes, and that will have endarterectomy, so that will have their plaque from their neck taken out essentially. And before that, they will receive fluorine MRI to see what the inflammation load is essentially. And the nice thing, of course, of taking this plaque out will be that we can then do ex vivo scanning and histology and confirm the amount of inflammation and perfluorocarbon that's present in there. So that will be happening in the very near future, end of this year or so. We should be able to start. Watch this space essentially. So in conclusion, everything together, we saw the first 4 things earlier up. Remember, you can't do cardiac MR with good motion correction, and all the other things are dependent on this. But I'd like to add on this from this last part that fluorine MRI is a unique imaging modality that can be used to monitor inflammation and to track cell populations. Thank you very much for your attention.
Thank you, Ruud, for this really nice presentation. The floor is open for questions.
It's very early.
Well, I have a few myself.
Very good.
I was wondering what is the half-life time of fluorine when you injected it, and if it's possible to use perfluorocarbons as theranostic agents for therapy, for example, atherosclerosis, to functionalize these perfluorocarbons.
So, and the first one depends completely on the particle and the type of perfluorocarbon that you inject. So this is one of the main issues, because again, they are completely inert, so they don't do anything, but they can cause volumic overload, right? If you just inject enough, the liver will take up more and more, and at some point your liver will stop functioning just because all cells have taken up perfluorocarbon. So the regulatory instances like the FDA and EMEA and so on, they want it to be cleared from the body very quickly. So the one we have here, that we're going to use in this trial, the ABL101 clears in about, as you can see here, has a half-life of about 5 days or so in the spleen, and a half-life of about 2 days, 3 days in the liver or so. And that's the longest storage organ that there is. So after that, it will be cleared out. But so you would have to wait for a week or two between, say, fluorine 19 separate exams. You can track it for over a week or so, and active processes will keep it probably even longer, but you have to think on the order of a few days. Then for the second part, can you combine it with therapies to do theranostics with it? Yes and no. The perfluorocarbons themselves are both hydrophobic and lipophobic, so they don't allow many things inside to be co-emulsified with them. However, if you have functionalized particles, like these nanoparticles that you can make, then you could attach things on the outside and whatnot. And a group in Nijmegen has now made these multi-compartment particles where you have, say, big globules of perfluorocarbon in, and other compartments where you can put targeted therapeutic agents. One thing that is also being investigated, and that's quite simple though, is to highly oxygenate the emulsion beforehand. And since they are smaller, these particles, than red blood cells, for example, after traumatic brain injury or stroke and so on, people are interested in injecting them because they might reach the affected area of stroke where blood cannot go directly, or red blood cells cannot go to oxygenate that area. So that's the limit of theranostics, I would say.
Thank you very much for your answer. There is maybe a few questions now. I saw a hand earlier.
Yes.
Yeah, thank you very much for this presentation. I was wondering, the images you show with fluorine were acquired at which field?
There's both some images from 9.4 and 3 Tesla. So the ones we are seeing here, there are 3 Tesla. But it's the mouse coil, right? So the coil to diameter like this in a 3 Tesla looks quite silly. But so it's sensitive enough for 3T as well. But for example, the ex vivo image that I showed of the entire aorta, that was like an overnight scan on a 9.4 Tesla.
And what are the typical T1 and T2 star of them?
Pretty much like proton imaging. So depends. It's also very heavily dependent on the oxygenation. So it can also be used for oximetry in that way. But heavily oxygenated, it's like 500 milliseconds, and then it completely in air or nitrogen, it goes up to 1500, 2000 or so. And T2s are on the order of 300 to 1000 or so milliseconds.
Thank you for the presentation. I have a question about the T1. Did you try to correlate with oxygenation, the T1 of fluorine? Oh, take a look. Maybe it's more quantitative, I don't know.
Very interestingly, I've only looked into this myself very recently, but the range of T1, basically how it changes as a function of oxygen, is quite large actually. So we recently just did a quick sample with another with a clinically approved perfluorocarbon that they produce in a small company in Nijmegen in the Netherlands, and essentially there the T1 with completely oxygenated, so a pure oxygen, was on the order of 400 milliseconds, and then the response the response of the R1 basically, so the inverse of T1, very linearly nicely decreases to the T1 equivalent of about 2000 or so in pure nitrogen. So you have this quite large range essentially of T1 to play with, and the response is linear for R1. So there have been some studies out there already where they do indeed just T1 mapping basically and use that as an oximetry equivalent.
Maybe introduce yourself quickly.
Hi, thank you for the talk. My name is Mariana. I'm from Lausanne. I was wondering, the anatomical images and the fluorine images, they are acquired sequentially. They're not acquired in parallel,
yes.
Right?
With our setup, yes, we have RF coils that and receivers and transmitters that can only do either or. So we need to wait for one or the other.
So Sorry.
There are centers though that have parallel or simultaneous transmitters and reception system, but those are even more unique than these broadband amplifiers and so on.
Okay. So how do you account for motion correction here? Because you have way less signal.
You don't, or you do simple ECG triggering as before, and let's hope things align essentially. Or what you often do is just ignore all ECG type things and just acquire. But if you image the heart itself, then you need ECG triggering to get anything resolved. Like the myocarditis images, they were just acquired with ECG triggering and so on. But for example, this abdominal imaging is just averaging, because I'll image for 10-15 minutes or so with a quite low spatial resolution. So all the motion averages out essentially.
Okay, even in the liver.
Yeah, especially in the liver. Yeah.
Okay, thanks.
Well, thank you, Ruud, for this nice presentation.
Thank you.
We'll welcome the next speaker, Dr. Bruno Caisson. He's a research director of the French National Scientific Research Council and head of imaging team at the HU Lyric. His research focuses on MRI-guided therapies, and today he will present us MR thermometry and beyond.
Okay, so first I'd like to welcome you in Bordeaux with this beautiful weather that we have today. We was going to improve by the end of the week, or I think from tomorrow they announce much better weather. So we discussed with Aurélien when he was organizing this Bordeaux to Lausanne meeting, and we decided I'm going to present MR thermometry and beyond, because probably something that not all of you are very familiar with. Hello. So let's start. So how can we map the temperature with MRI? Well, starting from magnitude and phase images, and then how can we convert this into temperature images? How and why? So let's start introducing this. The idea is really not to measure the temperature at one point, the absolute temperature, but really to monitor the temperature change during the ablation, because the idea beyond that is to be able to treat various diseases by increasing locally the temperature. This is something that is really commonly used, not within MR, but in clinical treatment for various pathologies such as cancer, where you can, for example, introduce a radiofrequency needle and induce local temperature change to burn pathologic tissues. So here the idea would be to do this under MR, and for this we would like to see what's happening in real time and what is the temperature distribution in space and time. And if we're able to do that, of course, we need to have at the same time a heating device inside the patient and inside the magnet. So this poses a number of challenges, technical challenges, to make this MR compatible. There are various energy sources that can be used. HIFU stands for high intensity focused ultrasound. RF for radio frequency, laser is light, and microwave. And if you're able first to monitor, this is the first step, then the next step will be to control. And the idea behind that is that you can use the real-time temperature images that you collect and compute to adjust the energy deposition inside the tissue dynamically. So the idea is to increase the safety and to make a treatment much more reliable. So this is an example. What you can see on the right, this is, of course, we're going to make a video, a movie. It's not just one image, but it's a dynamic imaging. And then we're going to analyze the contrast changing over time that are and to isolate the variation that are associated with temperature change. So the example that you see is a piece of meat. You see the magnitude images. You see this is the dynamic imaging, and then you see superimposed on that the temperature change with a local temperature change here induced with high intensity focused ultrasound. So why do we want to measure the temperature? As I said before, is to monitor a treatment, and a thermal treatment has the objective to create irreversible damage. And this depends on two parameters: the temperature exposure, how much temperature increase do I induce locally in my targeted region, and of course the time of exposure. And this leads to another concept, which is called the thermal dose. So the thermal dose is relies basically on the relies on the area under the curve of the temperature curve over time. And of course, if we're able to map the temperature change in real time, we should be able to have an idea to quantify the thermal dose. And this can be used as a clinical endpoint. So this thermal dose concept, it's important. It's linked to what is called the CEM, for cumulative equivalent minutes. And this comes from a quite old concept of analyzing the percentage of deaths of cells in culture. So this was a very old publication. And the researcher put some cancer cells in culture and exposed to a different temperature over time. And what they show is that if you want to ensure 99% of cell deaths, you should expose, for example, during 4 hours to a temperature of 43 degrees. And so this is very long. This is not something we want to do, of course. We want to do it much shorter. But I think that also analyzed what's happening if you increase the temperature by 1 degree, then you need exactly half of the time to produce exactly the same effect. And again, if you increase by 1 degree, iteratively, you decrease by a factor of 2. The time required to kill the cells. And if you iterate this process until, let's say, less than 60 degrees, you realize that you need less than 1 second to destroy the cells. So this, in fact, is described by this simple formula. Forget this part, it's for temperature, very low temperature increase below 43 degrees. But if you are above 43 degrees, this is exactly what's happening here. Each time you increase by 1 degree the temperature, you multiply by 2 the equivalent dose that you deposit into your tissue. And if then we are able to map the temperature in space and time using MRI, we should be able to map the cumulative equivalent minute, the thermal dose, in real time. So now comes the question, how can we measure temperature? Fortunately, there are a lot of parameters that modify the contrast on MR images and that are sensitive to temperature change. I did not mention specifically the advantages and drawbacks of M0 and MT. M0, of course, is based on the Boltzmann equilibrium. If you change the temperature, you change the population of the two levels, and that this is very difficult to measure precisely. Magnetization transfer has been proposed, but it's not used practically. You have also diffusion of photomolecules. This has the advantage of very sensitive, but this requires a lot of measurement to have a very precise estimate of the diffusion coefficient. T1 was originally proposed. This is very interesting, but it's this also requires several measurements to map the T1 dynamically. And also, of course, the other point is that the T1 change with temperature is tissue dependent. So you need to calibrate your T1 change versus temperature on each tissue you want to analyze. The most used parameter now is the frequency shift of the water protons. So basically what we are using is we analyze the phase of the images acquired using a gradient echo sequence. Okay, you have to keep in mind that this requires fat suppression because the fat does not change. The fat frequency does not change with temperature due to the chemical shift. But this change is related to the susceptibility. So this phenomenon takes place at the molecular level. This is between the hydrogen bonds between different water molecules that changes the screening constant. So this modifies the local B naught, not the B naught, but the B effective, the B0 that is seen by the protons locally, and this changes with temperature. So basically what we do, we have here two phase images on the left, one before treatment, this is the baseline, and one on the middle, where you can see clearly a contrast induced by a local change in temperature. And if you make the difference to get rid of all these phase wraps, for example, then you can isolate the temperature change. This is the phase change, and you can convert quite easily into temperature change using this formula. This says that the change in temperature is 0.01 ppm per degree. Okay, this is very low, but since we are detecting the signals in the rotating frame, the changes can be clearly seen on the phase images. The advantage of that is this method that it's linear with over all the temperature range of the liquids, so up to 100 degrees, and this is nearly organic dependent, so you don't need to have a specific calibration depending on the organ you're observing. Of course, you may have some issues, as always with MR. You need to have the most precise temperature measurement as you can. Ideally, it should be 1 degree or better. And this, of course, is related to the uncertainty of the phase measurement. So I plot here a vector of magnetization in red where you have high SNR. So of course, the angulation here for a given noise is given by this aperture here. And if you have exactly the same noise, but a much lower signal amplitude, then your uncertainty of the phase will decrease. And of course, immediately the uncertainty of the temperature measurement will increase as well. And of course, the worst case is when you have no magnetization at all, you have a circle around that, and which means that you are not able to have any precision on temperature. Okay, so the question now is, should I work at high field or low field? Because over the last 20 years, the vendors told us that we should buy higher and stronger magnets. I'm sure you agree. And now comes we have seen the last ISM-RAM, there's a tendency to go to lower. So this is here, you need, of course, to have compromise. And of course, you need to tune the acquisition parameters to have a very sufficient phase increase or phase shift to measure a temperature. And of course, if you have at very high field for a given echo time, you will get a very large angulation. So this is very nice.
But if you're at high field, the T2 star is shorter, then the amplitude of your magnetization will reduce. So this means that you should go to very low field. If you go to low field, of course, you will get a much longer T2 star. So the signal will disappear slower than at high field, but the signal amplitude will decrease because of the magnetization. So that's really a compromise. So something that I think we will be very interesting to look in the next generation or the current generation of magnet operating at lower field than 1.5 Tesla. So this is a practical formula that gives you an idea. You collect gradient echo images, you measure the SNR on the magnitude image, and this simple formula, given the echo time and the magnet you're working on, gives you an idea of the uncertainty that you should theoretically be able to reach. So if we take an example of 1.5 Tesla with an SNR of 15 and an echo time of 20 milliseconds, this leads to 1 degree standard deviation, which is acceptable. Okay, now comes the idea of the echo time. I mentioned it briefly. In fact, there is we can mathematically demonstrate that the uncertainty of the temperature is proportional to this simple equation. If you look for the minimum of this equation, depending on TE, this shows that you should select the echo time equals to the T2 star. This is the condition under which you get the optimal precision. And you have here an example of brain images acquired under 1.5 Tesla with a single shot EPI sequence, varying the echo time, and you can clearly see that you have a decrease of the standard deviation and temperature over this all these pixels here. And if we had increased the echo time longer, we should have seen an increase again. What is important to see is that although this theoretically says that you should be exactly at the T2 star value for the echo time, you have some flexibility. You can choose to be a bit shorter to get a bit more SNR if, for example, you need to exploit the magnitude images for some seagulls. And what usually happens, you can also have to take into account the constraint on the ablation device that you're going to use. For example, you can see here, this is an example, a very old example experiment we did on a pig. This is an example where you have a radio frequency needle that has been inserted into the liver. You see a very large artifact, a black part here, and the dot line shows the actual size of the device. So, of course, using this device, we are not able to monitor the temperature change at very close vicinity of the device, but you can still have an idea of what's happening at distance, which is what is really important into this application. The second part I would like to mention is that when you're using active devices to induce a temperature change into tissue, you also have to take care about the electromagnetic interferences that you can induce, and that will distort or destroy completely images. And this is an example on the right where you have a microwave ablation generator off, and you see that you have no artifact. But then if you simply switch it on and apply energy, you see on the case space that you have stripes coming that are related to the harmonics of the signals, electromagnetic signals that are produced by the generator that completely destroy the image quality. Okay. Of course, if you want to do this inside the MR, another point is the accessibility, particularly if you want to do percutaneous ablation and insert needle through the skin. And so comes also the question of using open magnet versus closed bore, and also having a closed bore with much larger aperture than the current systems. And of course, people are also willing to develop robots or actuators that can be manipulate device remotely inside the MR. So, as we know, management of motion is very difficult in MR, and it's not straightforward, so we need to put efforts on that. So the first thing you can do is, of course, trigger on the respiration, for example, if you want to make ablation inside the liver. And what you see here on the left is a temperature change, a temperature map, which is color-coded, superposed to the magnitude image of the liver of a pig. This is the color in red, the pixel that have reached a thermal dose equivalent to 4 hours at 43 degrees that I showed before. And this is the photograph of the explant after the ablation. And we compared into this series of experiments the size of the ablation measured on the tissue with the size of the ablation that is estimated from the thermal dose. And you can see that you have an excellent correlation curve with a slope very close to 1 and an offset below 1 millimeter. So this shows that the thermal dose is a good indicator to predict or to characterize the lesion that you are creating. This is another example that is more recent. All the technology that we have developed in our team has been transferred to a company that was launched 2 years ago. That's called Certis Therapeutics. And this is an example of treatment with microwave ablation of a patient with a liver tumor using microwave. And you can clearly see here that you have a temperature change, and you can visualize what's happening in real time, and also select some fiducial points where you can monitor the temperature change in real time. A few words about high-intensity focused ultrasound. This is very nice because the concept is to use an external device which is non-invasive, and you basically it's exactly the same concept as ultrasound imaging with two different things. First, you use a very concentrated ultrasound beam and very high intensity in order to create hotspots here. So what you see in this cartoon is that you are able to concentrate the energy in different locations inside the tissue, and this is done using a specific emitter, which is not a single emitter, but is composed of an array of emitters, and changing the electrical phase of each signals that is sent in each individual element will modify the constructive interference between all the individual fields, ultrasound fields generated by each emitter. And then using this, you can target deeper, closer, left, right, and in 3 directions. So this was combined with MRI. This is an example of experiments we did with in my previous lab with a Philips platform designed for the treatment of uterine fibroid, and we developed a research project to show that, to evaluate if we can do that into the liver. So using fast acquisition, single shot EPI, you can map the temperature in different regions. And using this rapid acquisition, you can have these 5 slices every 400 milliseconds. So this means that you can repeat that every 400 milliseconds. And of course, what you need is to correct for motion. So you have an example here of if I take the hottest pixels in my previous slide, let's say here, for example, and I map the temperature, the apparent temperature versus time. I've got this awful curve. This is before sending any energy, and during the energy delivery, you see the oscillations that are related to motion. So, but as the motion is quite repetitive, you can also use the first images that were acquired before the heating, create an atlas, and you collect different positions, and then each new incoming image is going to be compared in magnitude with the image of the atlas. You suppress the phase component that is related to motion, then you register the temperature map to the command position, and you're able to retrieve a correct temperature curve. I will show you a video. Where's my pointer? Okay, this is an example of this experiment where you see the liver moving. So the head is here, the tail of the animal is there, and at some point we collect the first imaginary motion, then we freeze the motion using image processing algorithm, and then you send energy. And what you see here is that you're able to visualize in real time the temperature change inside the liver. Of course, this is nice, but what's happening physically is that your liver is moving. You freeze the motion from MR temperature, but
you still have a fixed point. You're always sonicating, but physically your liver is still moving. So you're not concentrating the energy at the same position. And to account for that, one of our former students, Pierre Bourg, in fact, modified a bit the device. He selected a few elements that were used in reception and not in transmission, and using you select the surrounding elements, active elements from the ultrasound transducer to make a push, and you make an echo, and you make an echo simultaneously with four apertures, and using a temporal correlation of these signals, you can retrieve what is the displacement of your target in 3D real time. If you do that, this means that you can estimate the position of your target, and you can then adjust the phase of the phase signals on each element of your transducer to follow the target. So you make a tracking, which is only ultrasound based. Okay, and of course you can do a morphometry at the same time. If you do that, okay, I'm going to show you an example. So on the top, you see gel moving back and forth, and you have no correction of no beam steering of the ultrasound, and you see clearly the trace due to the motion. And on the bottom, forget the first images here, if now you correct both for the motion and temperature images and on the beam, you concentrate the energy. And if you look at the temperature, at the hottest point, of course, if you concentrate the energy, if you track the motion, you have a much higher efficiency in terms of treatment. We did exactly the same on the pig liver. So this shows that technically you can combine motion compensation on the MR images in real time with motion compensation of the ultrasound beam using ultrasound techniques. I'm going to go briefly on through cardiac morphometry. Here, the difficulty is that you need very high spatial and temporal resolution. So what we use is API sequence, which is triggered in the ECG and combined with the navigator, as was presented before by Ruud. And Valérie mainly developed a morphometry pipeline. And you can stream the data, the acquired data in real time, reconstruct the images, and then do a lot of processing to retrieve the correct temperature maps. This is an example where you see, for example, in a single pixel, the apparent temperature change if you do motion compensation on magnitude images. Then if you compensate for the phase changes that create susceptibility artifacts on the phase, you get this much nice curve, but you still get phase drift. And then if you correct the drift, and you can also add filters, you can end up with an uncertainty below 1 degree. So this is an example of a video on the heart of a sheep where you have a RF ablation. You can see in this central line is a zoom view of the top images and from the temperature, and the last row is the accumulated thermal dose in time. You can also use MR after the treatment to visualize the lesion. What's important here is to see the core of the lesion and the edema surrounding that appears as an hypo signal. So this can be done with the standard inversion recovery sequence without injection of corticosteroid agents by adjusting the inversion time. So again, what we show is that we have an excellent correlation between the size that we measure on the thermal dose images and the size of the actual lesion. Of course, you can do something much more sophisticated if you have catheters that allow to have, for example, microcoils on top of that, and you can track the motion. And if you do that, you're able to, you're able to see the temperature change, the thermal dose again, and look at the same time the electrophysiology signals that are modified during the ablation. Valérie implemented that onto the scanner and tested several patients, because of course then you might have the influence of arrhythmia, and this introduced a very nice concept that you find in the literature when you can plot the beat duration as a function of the beat duration of the previous beat, and if you have something very regular, you get a single point, and if you start to have arrhythmia, you get different patterns. But he showed that
although you have a very, very complicated pattern, even in presence of quite strong arrhythmia, you're still able to measure the temperature with a quite good quality. I want to finish rapidly with other applications where you can, for example, use this on small animals. This is an experiment that was done recently. And here the idea is also to predefine the temperature curve that you want to achieve in time. And then you're going to analyze the temperature change and adjust the power dynamically. This is a slide. This graph was stolen from Manon's presentation. So probably you will have to you can discuss with her later. And if you do that, for example, you can do on these small animals, you can, for example, analyze the influence of different heating patterns, different heating conditions on the cell survival, for example, in tumors. I'm not going to describe this into many details because we're running out of time. So in conclusion, MR thermometry is feasible on preclinical and clinical scanners. It can be used on most of the soft tissues. It relies on fast acquisitions. You need to have real-time image reconstruction and transfer because you want to process this on the fly. You need to compensate for a number of artifacts: susceptibility, motion, electromagnetic interferences, magnet drifts, and you need to develop dedicated instrumentation and workflow to optimize the treatment. You can also use not only this for monitoring, but also for controlling the heat deposition in real time. And this can be applied to various conditions for thermal ablation, but also for control of gene expression of our local drug delivery. So thank you.
Thank you, Bruno, for this nice presentation. The floor is open for questions.
Thank you very much for this comprehensive overview. I have a question. A stellar example, I think, you briefly mentioned this, is uterine fibroids. Mm-hmm. And HIFU has been shown to be very, very effective in treatment of these women, and pain goes away. And yet, for instance, in the United States, it's not approved for therapy. Now, on the one hand, you have a technique which people like yourself brought to a level where it can be used clinically to the great benefit of the patient. On the other hand, you have the frustration coming in because some regulatory mechanisms kind of hinder us to use these magnificent technologies to the betterment of the disease, or in this case, the symptoms. So what have you experienced with that here in France?
Well, the platform that we had a strong collaboration with Philips in my previous lab, and we had a chance to have the first prototype that was designed by Philips. So we did a lot of tests. This was a research project for the liver, but we also did some tests to qualify the system, and they were CE marked. This device is now installed in the hospital in Bordeaux and is used every Tuesday to treat patients. So I think the CE mark was obtained. It's also used in Asia. I think potentially what happened in the US is that Philips was running after GE and Insightec. That were the first, and the treatments were very, very long. And they promised that with their technology, they are going to be much faster. But in fact, I think they were not that fast as compared to what they were doing. At the end, the technology works. And now you see that it's more the patient who are pushing the pressure on the clinician to get this used. Because, of course, here the advantage of the technology is that it's much less invasive than surgery or other techniques. And young women that unfortunately can suffer from this disease, with the treatment can still have babies, which is something very important in life. But I don't know exactly what in the US, what's the blocking part, because even if the technology is working, it's not because it's working, it needs to be adopted. And
The reason why it's not adopted is not necessarily a scientific or a medical reason. It can be clinicians who of a given specialty who are reluctant to use that. With exactly the same technology, there is a French company using this approach with prostate cancer in Lyon. And they say the most difficult part was to fight against the urologist who had the patient, who refused to use this technique because then it's a part of their market that is disappearing. So it's not a normal reason, in my opinion, but this was the actual case. It took them something like 20 years to make this adopted for the prostate.
I just think it's a super important example for all the young PhD students here in the room, right, who think they are developing a wonderful technique. And at the end of the day, unfortunately, it's not the quality of the technique or the efficacy of the technique that is going to decide whether or not this is going to be applied in patients.
Yes, sure. It's developing the technology is a mandatory step. If you don't have the technology, there's nothing to discuss, of course. But it's not because the technology has been proven to be superior to the existing technology that is going to be adopted. If you look at catheter ablation, that here the clinicians are specialists into that. Initially, what we were doing when you had atrial fibrillation, you were doing open surgery and making a physical scar with a scalpel, and then you sew, and then you're done. But you had to open the chest, and it took them 20 years to show that you have exactly the same. You can do exactly the same thing with a catheter and RF ablation, radiofrequency ablation. And it was exactly the same story if you're thinking about the treatment of liver cancers using radiofrequency ablation needles. No, it's still the most reluctant people are the surgeons. But if you compare from the patient point of view, if you get surgery, you get 3 to 6 months at home to recover if you have a hepatectomy. And if you do radiofrequency ablation or microwave ablation, in 2 days you can be back at work. So in terms of the cost for the burden for the society, it's completely different, and so for the patient. But it's not always, I would say, normal reasons. But this happens all the time. I think the clinicians are quite reluctant. If they have something that is working, they are quite reluctant to modify the things. Something that is working, because they first need to do not hurt the patient. So this is important. And then comes other economic and different reasons. I think it's going, I don't know what's happening in Switzerland, but in France, for example, with radiology, there's a strong fear about do we need still radiologists? Because if AI analyzes automatically the images and gives you the results, do we still need to have radiologists? I mean, that's a real question.
Do you think that more clinical trials will convince clinicians to use more MR-guided therapies? It
depends. If you're thinking about what the company developed here, Satis, is the customer the radiologist, or is the customer a surgeon? That makes the difference. Okay. I don't know what's the plan with Siemens with the 0.55 Tesla. System. Well, if I was working at Siemens, I would say, okay, the radiology market is already established. If we could sell something to other specialists, for example, or to surgeons, this will open new markets. And of course, radiologists are not fan of that. Sure.
Not bench pipe, you want to sell it to private practice or different?
Yes, you can open the market, and of course, this is completely different.
You don't need you don't need a room like.
Yeah, sure.
That's the main.
Well, thank you, Bruno, and thank you, Ruud, for this nice session of Sunrise session.